Matthew Menendez with White Plume. I'm going to be walking you through the webinar this morning. Thank you again for your time. This webinar, again, is designed specifically for OBGYN practices, and we're going to be talking about ICD-10, how to protect your doctor's time, how to protect your revenue cycle today. So I hope that it will be helpful for you. Let's go ahead and jump right in, talk about what I hope to accomplish in the next 45 to 50 minutes. We're going to start with some general background information on ICD-10. Now, we're going to take a different approach than what you've probably seen before in other webinars. Most people know what ICD-10 is. We're going to start by looking at what makes ICD-10 difficult, and specifically what makes it uniquely difficult here in the United States. You hear a lot of people talk about how we're one of the last countries to move forward with ICD-10, right? We're one of the last World Health Organization countries to adopt ICD-10, and that's true. But there are some unique challenges here in the United States. It's going to be a more difficult transition for us than it is for a lot of other organizations, a lot of other countries. So we're going to take a look at what makes that difficult. Now, there are also a lot of practices who are behind in their planning, who are further behind than they'd like to be, and they're going to be trying to use these next few months to catch up and be prepared. I'm going to share with you some mistakes we've seen other practices make, so hopefully you can avoid repeating those same sorts of mistakes. All right. And then the last piece of introductory material that I want to share with you there's a lot of bad information, a lot of misinformation out in the marketplace about ICD-10. You see this a lot from bloggers, a lot from media outlets, where they're really using scare tactics that makes ICD-10 seem worse than it actually is. It sometimes makes it seem like an impossible task. It scares people, and they are paralyzed by that, rather than taking the necessary steps to move forward and to be productive. So we're going to talk through some of those so we can get a good, clear picture of what ICD-10 is and what it is not. And then we're going to jump in and get into some of the details to help you understand what tools and resources are available to understand what the impact will be to your practice. What will be the impact to your staff? What will be the impact to your providers? Where are those risk areas so that you can make sure that you're prepared to push back against those? And some themes that you'll hear through our time today, first and foremost, we're going to talk about physician productivity. If your doctors aren't taking care of your patients, nobody else in the practice is. If your doctors aren't generating revenue for the practice, nobody else in the organization is. And if your doctors aren't doing those two things, they're probably not going to be happy. And if they're not happy, nobody else is. So we've got to protect their time, right? We've got to have them focused on taking care of our patients. That's what they're trained in. That's what they're good at. That's what only they can do. But we also have to balance that with the real need of the revenue cycle that says once we see those patients, we have to turn that into cash. We have to be able to get those claims paid, and we're going to have to use ICD-10 codes to do it. So we've got to protect the physician productivity. We've got to protect the revenue cycle. Another theme that you'll hear throughout our time today is the difference between ICD-10 compliance and ICD-10 productivity. A lot of people make the mistake of thinking that ICD-10 is a compliance-only event. You kind of look at it as a pass-fail course in college. You want to do enough to be compliant, but you really don't need to do much more. I think that's a wrong way to think about ICD-10. Yes, it is something that you have to do, but there will be some practices who are much better prepared for ICD-10 than others. There will be some who are aiming at ICD-10 productivity, understanding the workflow changes that they need to make, understanding and putting strategies in place to protect their doctor's time, to protect their billing staff's time, so that they can be as efficient, as productive as they are today. The reason I bring that up is if you don't think about it, by default, a lot of people will take the strategy that says our goal is ICD-10 compliance. And those will be the practices struggling over the next 6 to 12 months. And we want to be able to push back against that. I will leave time for questions and answers at the end. If you're just joining us, there is a questions section on the GoToWebinar control panel. You can feel free to ask questions. I'll try to answer as many of those as I can. No need to hold those till the end. You can ask them as you go. Nobody else will see those except for me. So starting off, what makes ICD-10 difficult? What makes it uniquely difficult here in the United States? Well, the first thing is it's a one-day conversion, right? Everybody, I think, probably should know this by now. The ICD-10 conversion date is October the 1st. It's a Thursday. So it's a one-day conversion. That means there's no transition period on the front end. There's no grace period on the back end. On the front end, you have to do that on October 1st. You cannot do it early. You cannot phase this in. On Wednesday, September 30th, you have to use ICD-9 codes. On Thursday, October 1st, you have to use ICD-10 codes. You cannot miss that date. That's not something that can slip. Now, a lot of other countries had a one-day conversion as well. What makes ours different? What makes that more difficult here in the United States? I would tell you it's the lack of clarity surrounding the ICD-10 conversion date. Right? This is not our first ICD-10 day. Right? It's been delayed 3 times already. Twice by CMS, most recently last spring by Congress. The uncertainty surrounding that date makes it very difficult to prepare. You have a lot of people who are waiting and hoping that it might get delayed rather than taking the steps to be prepared. It's a lot like the story of the boy who cried wolf. Everybody probably remembers that from your childhood. At the end of that story, when the wolf actually comes, who pays the price? It's not the boy. I mean, yes, he's lost his credibility, but it's the sheep and the owners of the sheep who ultimately pay that price. It'll be the same way for practices who are unprepared for ICD-10. It won't be the government who suffers. Yes, they've lost their credibility, but it'll be the practices and their doctors and their staff and ultimately their patients who are left struggling, trying to catch up. That's one of the things that makes ICD-10 difficult. It makes it hard for administrators, billing managers, ICD-10 project managers to help prepare their organization, particularly when you may have people in your practice who are saying, no, let's not get ready, let's not take the steps, let's not invest the time, let's not invest the resources to prepare because we're hoping that it's going to get delayed again. A lot of practices struggle with that. Another thing that makes ICD-10 difficult here in the United States is that it's a big change for physicians. Now, you could say that, well, wasn't it a big change for doctors in Canada and England and France and Australia when they moved to ICD-10 as well? Sure, it was a big change for them, but those physicians are government employees. Ours are not. Our physicians are small business owners. And they cannot slow down. We operate in a fee-for-service world where they're not salaried, they're paid off their productivity. And they cannot slow down and see fewer patients and generate less revenue as a result of an unfunded mandate like ICD-10. The other piece of this that makes it difficult here is most doctors are not interested in ICD-10. They're not interested in the code set. That's not why they went to medical school. And they don't want to spend the time over the summer to learn about the new code set. If you had a meeting tomorrow evening, how many are going to show up to learn about ICD-10? Not very many. So as a project manager, how do you prepare them? How do you protect their time and make them be productive in an ICD-10 world if they won't show up to learn about it? That's very, very difficult. So we're going to talk about some strategies of how you can do that. But the last piece is what I think makes ICD-10 most difficult for practices here in the United States. We've had a lot of intervention from the government over the last 5 or 6 years, right? E-prescribing, PQRI, which turned into PQRS, meaningful use. All of those were government programs that were optional, that offered an incentive plan, that were phased in over time, and maybe carried a penalty down the road on your Medicare or Medicaid reimbursement. None of those things are true of ICD-10. It's not phased in, it's overnight. There's no incentive. The penalty is immediate. It's not Medicare, Medicaid only, it's all of your payers. It's a much riskier change. 100% of your cash flow is at risk overnight. It's not just your government payers. All HIPAA-covered entities are required to move to ICD-10, and there are no additional dollars for the practice to support this transition. And it's not just about getting codes out the door on the claim. You have to make sure that it's coded correctly, that you jump through the hoops and hurdles required by the different payers. And sure, Medicare wants it one way and Blue Cross wants it another way. That's the world we're going to operate in. And it makes it difficult for a practice to be successful. You've got to plan ahead. And if you're trying to catch up, if you're behind, let me share with you some of the mistakes we see other practices make. A lot of practices wrongly assume that ICD-10 is really just a coding project. Some of you may be in this boat. You look around your practice, you find the coder, you find the billing team lead. That's the person who needs to learn about ICD-10. That's the person who will send to classes. Nobody else is really going to have to worry about it. They'll take care of it, right? And yes, ICD-10 is a big change for billing teams and coding teams, but that's only part of a successful strategy. A similar mistake that other practices make is assuming that it's really just an IT upgrade, right? Every ICD-10 checklist you've ever seen talks about talking to all of your vendors. That means your clearinghouse, your practice management vendor, your EHR vendor, and making sure you're on the right version of their software. And again, that is an important step, but it doesn't go far enough. That's really only focused on ICD-10 compliance, not ICD-10 productivity. It's not enough just to be on the right version of the software. You need to understand how it works. What types of workflow changes are you going to have to make? Can your doctors do that? Can your staff do that? Can your billers do that? Does it produce the type of results that you need? How long will it take those users to be trained in that new process? How long will it take them to actually do that day in, day out? If you just ask your vendor, will you be ready for ICD-10? The answer will always be yes. When you push a little bit harder and ask the next question about show me how it will work, show me how it will work in my environment, sometimes the answers are a bit different. You have to view ICD-10 as a strategic initiative, and that means getting your management team on board, getting your doctors on board. They don't have to be in on every meeting, but they do need to understand what the risks are and what strategies you have in place to mitigate those risks. Right? The big two risks associated with ICD-10 for OBGYN practices are, number one, the risk of declining physician productivity. And number two risk is the revenue cycle. And when I say revenue cycle efficiency, what I mean is think about your revenue cycle. How many billers, how many coders do you have today? How many hours do they spend a day trying to collect your cash flow? Because in ICD-10, if you have to spend more hours, more staff to generate the same cash flow, that's a bad outcome. If you don't hire any additional people, you don't work any overtime, but you collect less cash flow or it takes you longer to do it, again, that's a bad outcome. We want to protect against that. And I'll share a study with you that was done by the advisory board looking at this. They tried to look at Canada's transition to ICD-10 to see what the long-term costs were. What were the post-implementation costs, the productivity losses, right? Because those are the costs that go on forever. And look what they put front and center. Physician productivity. 10 to 20% decrease in physician productivity as a result of ICD-10. Now, that sounds ridiculously high. Even if you cut those numbers in half, they are unacceptable for a busy OBGYN practice in the United States in a fee-for-service world. It cannot happen. You want to get underneath those numbers, understand what was happening. They had coders that were coding from the documentation, and they would have to go back to the physician to ask for additional information. Be more specific. Can you tell me about the stage of the disease? Can you tell me more about the etiology? Right? I need to know the number of weeks gestation. I need to know which fetus we're talking about. All that back and forth about the new detail in ICD-10 is what took up the doctor's time, and it was on average 45 to 90 minutes per doctor per day. Again, even if you cut that in half, where your doctor is going to find an extra 22 to 45 minutes per day to answer these types of detailed follow-up coding questions? They can't see fewer patients, and it's not fair to expect them to do that at the end of the day rather than spending that time with their families. That's why we're going to spend time talking about this. That's why you need to have a strategy in place to protect against that. Now let's look at the right side and left side of the screen as well. On the left-hand side, you see coder productivity. If you don't have coders in your office, you can replace that with biller productivity. You'll see that declines significantly in the first year, but they do regain some of that productivity as they get up the learning curve. But they won't get back to today's level of productivity. The expectation is the long-term productivity loss for billing staff, for coding staff, will be somewhere between 5 and 10%. That's not their fault. ICD-10 is just more detailed. It's a bit more complicated than ICD-9. Right? So we don't want to have to hire additional staff there. We don't want to have to work overtime hours there. We have to think about our process. How can we make them more efficient? And then if you look at the far right-hand side of this screen, you'll see the rework productivity. That's a result of an increase in the denials, adjustments coming from the payers. That seems to match up with some of the early end-to-end testing results that we've seen so far this year. When Medicare has done their end-to-end testing, denial rates have been doubling or tripling for most practices as a result of ICD-10. Now, you cannot control the external carriers, but what you can do is make sure that your internal process is in the best shape possible. You know, if you have a 2-3% denial rate today, that may go up to somewhere between 4 and 9% as a result of ICD-10. You know, that's one of the reasons a lot of people recommend having a good line of credit in place. That's a prudent decision. But what you want to do is make sure you are prepared so that you're on the low end of that spectrum rather than on the high end of that spectrum. All right, now the reason why we do this is we want to take a good, clear look at what makes ICD-10 difficult. But I don't want to be all doom and gloom because there are some misconceptions out there in the marketplace that ICD-10 is more difficult than it actually is. So let me talk about those for just a minute as well. One of the things you hear a lot of people talk about when they talk about ICD-10 are all of the new codes, right? The increase in the code set. And this is true. There are 69,000 codes in ICD-10 compared to only 16,000 in ICD-9. But the fact of the matter is you're not going to use all of those codes. Most practices use less than 2% of the entire code set. And that'll continue to be true in ICD-10. Don't worry about all the codes that you don't use or won't use. Focus on the ones that you do use. And we're going to show you how to do that. A lot of people get distracted by some of the new codes, particularly some of the crazy codes that seem ridiculous, get a lot of airplay, right? You see this all over the place, and there are comical things about some of the codes in ICD-10. This is probably the most infamous ICD-10 code, V91.07XD. You've probably all seen this before. It's this flaming water skis encounter. A lot of people like to point out how crazy and ridiculous that is. And they extrapolate that to say, if this is what ICD-10 is like, we could never be successful with that. Now, what most people won't tell you is, believe it or not, that code, or a very similar code, already exists today in ICD-9. And I bet nobody on the phone today has ever used that code. You don't use it in ICD-9. You won't use it in ICD-10. A lot of the crazy codes that people like to make fun of already exist in ICD-9. They're actually E-codes in ICD-9, external cause codes. Medicare, CMS has already come out and said, if you're not using these external cause codes today, that there's no new national mandate requiring you to use those external cause codes in ICD-10. So don't let those distract you. Focus on the codes that you do use. Particularly, I think one thing that a lot of people miss is the silent killer, right? Everybody knows unspecified codes exist in ICD-9, and they are going to continue to exist in ICD-10. A lot of practices use these as a catch-all. They use it to save space on a paper charge ticket. They use it to make the documentation in their EHR a little bit easier for the provider. And it's really no harm, no foul in ICD-9. For the most part, those are payable diagnosis codes, and there's no downside to using them. And that's not true in ICD-10. There are two risks in ICD-10 to using unspecified codes, a short-term risk and a long-term risk. Let me talk briefly about both. The short-term risk that most practices will probably see in the fourth quarter of this year or the first quarter of next is that those unspecified codes don't get paid. You'll have payers that start to deny those claims. And here's why. If you think about it from a very high level, the reason the payers advocate for ICD-10, the reason they lobby Congress not to move the date again, the reason they've invested millions of dollars to rewrite their own internal systems, their own adjudication processes, is because they want the more granular diagnosis information. They want the more detailed diagnosis codes on their insured patient population so that they can ultimately use that information to drive down healthcare expenses. That's why the federal government wants that data. That's why the commercial carriers want that data. And if the provider community does not give that to them, the claims are going to get denied. That may not happen day one. It may not happen in the first 6 months for some of your payers, right? Payers will probably handle that differently, but that will happen in the short term. The long-term risk to using unspecified codes in ICD-10 is that we are eventually moving away from the fee-for-service model, right? We're moving into a world for pay for performance, pay for quality, outcomes-based reimbursement, right? You can use any word that you want to for that. But in that world, it's all about the expected outcome versus the actual outcome. It's all about the severity and acuity of your patient's diagnosis. And you need the more detailed, you need the more granular diagnosis codes to show how sick your patients are. You think about the difference between an unspecified pregnancy and a high-risk pregnancy complicated by pre-gestational diabetes and hypertension in advanced maternal age. Those two patients look very different, but you have to use the more specific ICD-10 codes to show how sick your patients are to maximize and maintain your reimbursement in an outcomes-based reimbursement world. So you've got to be careful about those unspecified codes. That's why we recommend focusing on the codes that you use today and seeing how they translate into ICD-10. This is called ICD-10 conversion analysis. We've done this for all of our clients. I thought it might be helpful to share some of the data with you. What you'll see is across specialties, most practices use somewhere between 200 and 300 ICD-9 codes today. that cover the majority of their patient encounters. So you take those and you convert them into ICD-10, and you'll see two things: a significant increase across specialties. Significant increase across every specialty. OBGYN's on the higher side. At least you're not in orthopedics, right? And then we go a step further, because not all codes are converted equally, and we put those into risk categories. We put them in low risk, moderate risk, and high risk. I'll show you examples of each of these, but let me explain. The low risk codes, those are the ICD-9 codes that can be converted directly to one code in ICD-10. One code in ICD-9, one code in ICD-10. Everybody loves those. For most OBGYN practices, 45 to 50% of your most commonly used ICD-9 codes fit into that category. Unfortunately, the others do not. The moderate risk codes, those are the ICD-9 codes that have between 2 and 10 choices in ICD-10. The high risk are those that have 11 or more. So we put those in the risk category just because it makes it a little bit easier to talk about those and to show you some examples of each. Let me do that for just a minute. I'll show you an example of what we call the ICD-10 conversion analysis. What you see up at the top in red is the summary data, the same thing that you saw on the previous slide. But then look down below that. You get the line-by-line detail that shows you for this code, B72.42, an encounter for a positive pregnancy test, one code in ICD-9, one code in ICD-10, and it gives you the new ICD-10 code and the new ICD-10 description. That's an example of a low-risk ICD-9 code. The next example, 455.6, hemorrhoids, one code in ICD-9, 5 codes in ICD-10. You can see what the codes and descriptions are: first, second, third, fourth degree hemorrhoids, but you also have a code for unspecified. And then if you scroll down even further, you'll see 648.03, and that is pre-existing pre-gestational diabetes. And you can see this is where you need to be more specific in ICD-10, not just about the type of diabetes, but also about the trimester of the pregnancy. Now, I share this information with you for two reasons. Number one, I think it's a great place to start. If you haven't done something like this already, I highly recommend doing ICD-10 conversion analysis. We actually provide that as a free service for people who attend one of our webinars. So if you would like to do this ICD-10 conversion analysis, you can use the questions panel and just let me know, and I'll have somebody follow up with you to share that with you. And the reason I recommend that is because it's helpful information to share with your staff, to share with your providers. And the reason why is it tends to relieve some of their anxiety about ICD-10. They can look through this and say, yes, there's an increase, but I look at the descriptions, I look at the new codes, and I can see the new concepts in ICD-10 are not foreign, they're familiar. I know the difference between type 1 and type 2 diabetes. I know which trimester the pregnancy is in. That's doable for me. I don't see anything on here about walking into a lamppost or being bitten by an orca whale or struck by a turtle. None of those crazy codes are going to show up here on your conversion analysis. So I like to share that with people within the practice. I think that's a great place to start. The other thing that I think it does is I think it points out that the status quo is changing. We can't just use 254 codes now. It's going to be closer to 1,400. And here's what they are, right? If you're a data person, if you're a numbers person, this is a great way to look at it. If you're more of a visual learner, let me show it to you this way. I'm going to pick on the American Academy of Family Practice for just a minute because they put this on their website. It's an ICD-9 fee ticket, charge sheet, super bill, whatever you want to call it. right? And it looks like every super bill that I've ever seen. It has CPT codes on it. It has diagnosis codes on it. Very fast, very easy for the provider. Now, what really caught my attention is they also had an ICD-10 version. And the ICD-10 version looks like this. The front side doesn't change, right? CPT codes do not change on October 1st. What about the back side? What about the diagnosis side? Now, when you look at this, it looks like this. It's 8 pages long. Now, that may be a good example of an ICD-10 compliant solution that's not at all ICD-10 productive. Can you imagine trying to put an 8-page charge ticket in your provider's hands and asking them to do that? Can you imagine the headaches that that would cause at checkout? That won't work well. And I'm going to use this as one example of how to think about the difference between ICD-10 compliance and ICD-10 productivity. That won't work well. So what we want to do, you can't use an 8.5 by 11 inch piece of paper to fit all of those codes, and a jumbo super bill won't work very well either. So yes, part of that is a real estate concern. I can't fit that number of codes on my same piece of paper as I do today. But many of you may be thinking, well, we don't do that today, right? We have doctors that write in a description, or maybe you have coders that are coding from the doctor's note, or maybe you're doing that through your EHR. But I want you to remember, it's not just the codes that change. It's the descriptions. It's the documentation concepts. Because if you just have somebody writing in and they write, pre-existing diabetes, you're right back to that problem that they had in Canada. The back and forth communication of, I need you to be more specific. Is it type 1 or type 2? What trimester is the pregnancy in? And that's what we want to avoid. We don't want to turn our doctors into coders, but we have to have the right codes to get the claim paid. And so when you start thinking about your workflow for a problem like this or something else, you need to think about what makes it work so well today. Why does that work so well today? We did a survey last fall and found 54% of practices, regardless of EHR adoption, or which EHR they use, are still using the paper super bill, which clearly won't work in ICD-10. Why do they still do that? I think it's because it works so well for the doctor. They know that form so well, they can probably fill it out with their eyes closed. They know where the codes are on the page. And it gives the billing team the data that they need. So when you start to think about the solution, when you start to think about how are we going to handle this in our workflow, you need to think about what makes it work so well for you today, assuming that you've got a good process in place. So let me give you three options of what we've seen practices do, and I'll talk through each of them. The first one, I don't see a lot of private practices do. I see this more in the hospital setting, but is to hire certified coders. The issue with this is really financial. Most practices can't afford to hire coders for the high volume of office visits that they see, their high encounter volume, because coders are expensive and the volume is high. But if you're thinking about going down that road, the challenge for most practices is that coders are getting more expensive, and at the same time, they're getting less productive. That's not their fault. ICD-10 is more complicated, but that's the challenge for groups who try to go down that road. for most administrators, is if your doctors complain about this today, if they say that it takes too much time in ICD-9, that gets worse, not better in ICD-10. And again, it's not the vendor's fault. What you have to check on if you're planning on going down this road is how has your EHR vendor solved the ICD-10 problem? Many of them have solved it through a code search mechanism. It sounds easy enough. You know, you put 69,000 codes in a database, you type, you search, and you get your result, and you choose the right one. And it sounds easy because we've been trained to think of search like Google, right? We use those words interchangeably now in our vocabulary. But the way that Google works is different from the way that code search works. When you're searching Google for apple pie or a good Thai restaurant or directions somewhere, 99% of the time the answer to what you're looking for is the first or maybe even the second search result. That's why everybody fights to be at the top of the Google search results. That's why SEO is important. But diagnosis search doesn't work the same way. Think about it. If you search for diabetes and you get 50 search results in ICD-10, you have to read through all 50 results to choose the one that's most accurate for that particular patient encounter. The first result is not always going to be the correct result. Many times, the first result is actually an unspecified code. Because of the way the code set is organized, if you sort search results by code, which many vendors do, the first search result is often unspecified. See, that's why you have to think about, how is my vendor solving this for me? Will that work for my doctors? Will that work for my revenue cycle? Now, I'm certainly biased, but I like option number 3 the best. It's an electronic super bill, designed in such a way to protect the doctor's muscle memory. It looks like the paper charge ticket does today. And that saves you time in training the physicians, and then saves them time when they're actually using the application. It also balances the real need for the billing staff to get the right code the first time so that they can get the claim paid correctly and completely the first time. Again, I told you I'd show you some examples, so let me do that because sometimes a picture's worth 1,000 words. This is Capture, again, an electronic super bill. It's custom designed for each practice. And so let me go through it and show you an example. I'll do one in ICD-9, and then we'll turn around and do the exact same encounter in ICD-10. So, you know, maybe we do an initial OB visit and an ultrasound, and then I flip over to the back side and I've got my diagnosis codes, right? And I'm going to go ahead and pick 3 diagnosis codes. We'll do a low-risk code like positive pregnancy test. I'll come down here and do hemorrhoids, and then we'll do pregestational diabetes. You know, pretty easy. 1, 2, 3, I'm done. Right? Everybody usually understands that, gets that in ICD-9. Now let's do the exact same encounter, this time in ICD-10. I want you to think about this. Pretend that I'm one of your doctors. I haven't come to any of the ICD-10 training classes. It's Thursday morning, October the 1st. I'm going to walk in and try to figure this out. Right? Let's do my first patient visit. We'll do the exact same thing. Initial OB visit, ultrasound, exactly like it was the day before. No change to CPT codes. Well, what about the back side? Is it going to be 8 pages long? Is it going to list out 1,500 ICD-10 codes? No. This is the magic of what you can do with an electronic super bill. It looks exactly the same as it did the day before. All right, so far so good. Let's do that first diagnosis, positive pregnancy test. When I click on that, what you'll see, the first change is it's green instead of yellow. That's a visual cue to me as the user to know that something's different. This is one of those low-risk codes that can be converted automatically from ICD-9 to ICD-10. It puts in the new ICD-10 code, the new ICD-10 description for me, but I didn't have to do anything else. I love those. Again, for most OBGYN practices, Typically 45 to 50% of the codes that you use most frequently can be handled like that. So let's look at something a bit more complicated, like that diagnosis of hemorrhoids. When I click on hemorrhoids, you'll see it cannot convert that automatically for me. So it gives me the pop-up and shows me my choices. So I can click on first-degree hemorrhoids. It closes the pop-up automatically, puts in the new code, puts in the new description, and I'm done. All right, so far so good. Let's look at this pre-gestational diabetes, a bit more complicated. When I click on it, rather than listing out all 15 choices that I have to read through all of my options, it's organized it for me into 2 dimensions. It's got the type of diabetes on the vertical axis, and then it has the trimester on the horizontal axis. So what that lets me do is, if it's type 1 diabetes, first trimester, I've got 1 extra click. Again, it closes the pop-up window for me automatically, puts in the new code, puts in the new description. I'm done. Trying to make that easy, trying to make that a non-event for my providers. You know, one last thing that I'll show you on this rank and link tab. This is a summary tab. It shows everything that's been selected. One of the things that some of our practices really like about this for their doctors who are still dictating or documenting manually is they can view this screen, or sometimes even have staff print it out for them, so that they know where they need to be more specific in their documentation. They can't just say hemorrhoids. They need to say first-degree hemorrhoids. They can't just say pre-existing diabetes. They need to say pre-gestational diabetes type 1, first trimester. That's a reminder of where I need to be more specific in my documentation. That lets me learn as I go, rather than investing a lot of time up front to learn the new code set. That makes ICD-10 easy for your doctors. Now, I've spent a lot of time talking about the providers, because if we don't take care of them, the rest of this really doesn't matter. But let me spend the last 5 minutes talking about the revenue cycle, and then I'll try to answer as many questions as I can. When you think about the revenue cycle, it is a big change for them. And it's not just a one-day change for your billing team. Right? They're going to be dealing with ICD-10 and the changes that it brings about for months and years into the future. So when we think about that from a very big picture perspective, you get paid for CPT codes today. And you have to have a diagnosis code that makes it medically necessary. That's true in ICD-9. That's true in ICD-10. But it's not that easy. You have to jump through all the hoops and hurdles by the payers in order to get those claims paid. And on top of that, each one may want that done a little bit differently. Blue Cross wants it this way, Medicare wants it that way. Right? You've dealt with this for the past 30 years. You probably have people in your office who know this in their head. They've kept up with the changes. The problem is that cat and mouse game, the head knowledge that your employees have, goes out the door overnight. Right? The cat and mouse game will continue, but the rules of the game will change. And remember, the payers have not done this before either. So they're not going to handle that in a consistent manner. And they're going to be making changes as they go. Right? What that means is they're going to be making changes to their adjudication algorithm. So over time, we're going to see changes from the carriers as well. That's why this is not a one-day change for the billing and the collections department. Right? And the volume of change, the rate of change is going to be much higher and much faster than anything we've seen in our careers. So you have to ask yourself, if that's what the world is going to look like, how are we going to handle that? What types of processes do we need in place? What types of tools and resources do we need? Who on our team is in charge of that? And maybe the scarier question is what happens if you don't do a good job of that, right? What happens to your cash flow if you don't do a good job of that? For the billing team, ICD-10 will be a marathon, not a sprint. And if you're going to run a marathon in October, you need to start getting in shape for that today. The best thing that you can do is get your denial rate as low as possible. Make sure you have a good process in place for responding when changes do come from your payers. We recommend this for all of our clients. Anybody can do this. You know, we certainly can provide some software to help with this, but anybody can have a process like this. Here's what we recommend to our clients. You're not going to rid the world of denied claims. You can't change the payers. That's going to happen in ICD-9. It's going to happen in ICD-10. But when you see a new denial, when you see a new policy, go through this type of process. Go back to the beginning and figure out what went wrong. Why'd that claim get denied? And how can I build a new rule to make sure that that doesn't happen again? We encourage them to build that rule into software so you're not relying on people to remember that. So that whether that exact same scenario occurs in 2 hours or 2 weeks or 2 months, that rule is going to fire the exact same way for every single employee, whether it's your most senior certified coder or your newest billing clerk. They all get the access to the actionable information at the right point in the revenue cycle so that they can make that correction before the claim is even posted, so that they don't make the same mistake over and over and over again. That's closed-loop denial prevention. And if you can put a process like that in place today and minimize your denials, put a process in place like that today so that you're prepared when you have to start making these changes. You've practiced your steps. You've practiced your process. That can make the difference between ICD-10 compliance and ICD-10 productivity for your revenue cycle. Now, last slide, and then I'll try to get to as many questions as I can. I want you to think about what you want your practice to look like in October of this year. What do you want your office to look like in November of this year? What's the goal? What's the objective for your providers? What's the objective for your revenue cycle? Is the goal to be able to submit claims with ICD-10 codes on them? Or is the goal to make sure that you've understood the process, that you've optimized your workflow for the new world of ICD-10? You know, are my doctors, are we going to be able to protect their time? Or are they going to be staying late to answer coding questions? And the reason they got into medicine is because they wanted to take care of patients. That's what your patients expect. That's what your doctors are best at. And we want to make sure that remains the case in ICD-10. Because your patients aren't thinking about ICD-10 at all. They're going to expect the same high-quality service that they get today. And what about your billing team? Are they going to be working nights and weekends trying to get claims out the door and managing that back and forth process with the doctors? Hey, I need you to answer those coding questions for me. Or are they going to get the right data that they need to do their job correctly the first time? Are they going to have the types of tools and resources and processes in place that they need to respond to the changes that are coming from the payers? Or are we going to have to hire additional staff or outsource part of our follow-up to keep up with that work? That's the challenge of ICD-10. If you have to hire additional employees, there's no additional reimbursement dollars to do that with. So ultimately, at the end of the day, if you're not well prepared, the practice will probably be less profitable than you are today. I don't say that to scare you. I say that to help you prepare ahead of time, rather than being surprised when you're unable to pay physician bonuses in the fourth quarter. It doesn't have to be that way. You can be successful in your transition to ICD-10, but you've got to work ahead of time. you've got to make sure that you're prepared for the changes that come. I hope that some of this has been helpful for you. I hope that you're encouraged in your ability to be successful in the ICD-10 transition. If there's anything that we can do to help you, please let us know. We'll try to do our best. But thank you again for your time. I'll try to answer as many questions as I